back. Now, 1 in 5 couples in Kenya suffer from infertility. At least 4.2 million Kenyans need interventions to conceive. But what happens if they don't know about the assisted reproductive technology available? And even if they did, what happens if they cannot afford it? Well, the lives of Priscah, Adoyo and Hellen Apiyo, 2 women from Homa Bay County who have borne the burden of being childless, answer those questions. Tonight, we leave you with our special report, The Luur Dilemma.
Anaitwa Luur. Hajapata mtoto, anakuwa barren kabisa.
A woman who doesn't have a child is actually considered not married in most communities. Like amongst the Luo, you are called a Luur. A lot of people will taunt you with it.
Hawataki mwanamke ule sahi. Sasa kitu chochote kitokea wanaweka juu yangu.
When Hellen Apiyo got married in Adoyo Wino's homestead in 1990, she knew that her womb would not wait too long. But after a year, it was silent, and she was childless. But the people around her were talking. Her husband bowed to the pressure. But as much as it was coming from without, it was also coming from within.
Nilikuwa naona marika zangu zote walikuwa na sasa na watu wao yani. Na mimi vile tulikuwa nakaa hatakuwa na mtoto. Sasa kwa roho yangu ilikuwa mzuri sana.
Lakini ile shida ilikuwa tu juu ya uzazi. Sasa tulikuwa mengi. Siwezi sema.
More years went by, Hellen was still childless. According to the Kenya Fertility Society as of July 2018, 1 in 5 Kenyan couples suffer from infertility. Experts estimate 15% to 20% of the Kenyan population need intervention and assistance to conceive.
According to the World Health Organization, when you talk about primary infertility, it means that you have a couple who are in a relationship or maybe want to have a child, and they have been having regular intercourse 2 to 3 times a week. They're not using any contraception, and during a period of 1 year, no conception has happened. So that is primary infertility. But in secondary infertility, you have this couple, again, who have regular intercourse 2 to 3 times a week, no contraception, the lady is not breastfeeding, and in a period of 1 year, there is no conception. However, they have had a child before, or they have had a pregnancy before, and they are trying to have another one, and it is not happening.
In men, the reasons are quite varied, ranging from blocked tubes, sexually transmitted infections, poor production of sperms, testes that didn't descend during development, and even surgery. The risks are increased by factors such as trauma, heat from activities such as prolonged placing of laptops on the laps, smoking and drinking alcohol. Dr. Kireki Omwana, a consultant obstetrician, gynecologist and still a fertility specialist, notes the same in women.
Age is one of the biggest factors. Most ladies don't know that once we cross 35 years, the fertility actually does drop, and it drops drastically. Ladies should know, they should have themselves checked. If they have the chance of having a baby, or even having their eggs collected and stored so that they can use them later on, that is also a good thing. We have a problem in this part of the world with blocked tubes. That actually, in my practice here, I think I would say about 80% or even 90% of the patients that I see have blocked tubes. The other problem that we have in this part of the world is fibroids.
Polycystic ovaries, conditions such as endometriosis, diabetes and hypertension, as well as surgery, predispose women to infertility. In sub-Saharan Africa, most of the time, infertility and childlessness is often a woman's fault.
We don't really think that infertility can affect men. But then interestingly, we find that about 35 to almost 40% of the cases of infertility or the causes of infertility actually affect men. And about 30%, which is less than the men, this is what affects women. And then about 10% you find it is both. And then about 4%, maybe about 5% are the ones which we call unknown causes. But the problem actually does affect men more than it does affect women.
This is Homa Bay County, famous for its bays and also all the activities that are sustained by the Lake Victoria. When it comes to birth rate, Homa Bay ranks high among the top 10 counties in Kenya with a birth rate of 48 for every 1,000 people. However, not all women are able to have children of their own. There are women with silent wombs, waiting wombs, and that is what this story is about. When Helen was in class 7, she used to experience sharp, persistent low abdominal pain, but she never received any diagnosis. The years went by. She was growing older. Still, no children. In the Luur community, cultural biases were inherent in conception, sexuality, manhood, and masculinity. A man unable to have children was even considered a boy. Each clan had to find a way to continue the bloodline.
Ndugu yangu mkubwa alioa, akaishi na mkubwa karibu miaka 3-4 hivi. Hawakupata mtoto. Vile mdogo aliingia tu hivi, mdogo akashika mimba. Hiyo mwaka tu mkubwa pia ameshika mimba.
Owino married another wife after Helen in the first 2 years of their marriage, but after 6 months, that new wife died.
Kakufa. Wakaleta maneno tena sana eti kifo chake kilitoka kwa mkono yangu, lakini mimi sikujua.
Then and even now, a childless woman didn't have many options.
The older wife was not able to have children, and culturally she was allowed to then marry for her husband another wife. And when she culturally marries, the wife is hers, it's not the husband's. So once she brought this woman, the woman has a child with the husband, but the children are considered her children. So it's a form of surrogacy, except because there's no technology involved, then it actually involves the husband actually physically engaging with another woman, who then traditionally is not considered a wife. So even traditionally, it was acknowledged.
In mid-2002, a new wife was found. Benta Anyango Ayo, now aged 37, came here in her mid-20s to fill that gap. She has since given birth to 6 children, the oldest being 14. They consider Helen their mother.
Niko na hao watoto. Niwachukua kama wangu. Hawana maneno. Ninawatuma na wakatai.
Not far from where Helen and her husband live, 64-year-old Priscah Adoyo close out a tolerable existence for herself. Life has taken away her youth and given her in exchange an uncomfortable truth. Her womb will never carry children of her own.
Mimi hakusa na ule mtoto nimeleta, ni mtoto ya simeji yangu. Nimeleta hapa ati ukae hapa kuliko kununua dongo. Ati mwingine ndio anakuja kukaa.
Priscah tells us that she tried to find a younger wife who would bear children for her.
Mzee alikuwa mzee mkubwa sana. Wasichana alikuwa hapa naweza kubali. Nimejaribu lakini kila msichana alikuwa ni mzee hataki. Ni mzee hataki.
One of her husband's nephews is the one who stays with her often and fills the void she has borne as a childless woman. This form of surrogacy may have worked for just one parent, but Helen was not aware of assisted reproductive technology available to assist women and men with infertility problems to have biological children of their own. Assisted reproductive technology offers hope to couples with fertility problems such as low sperm count, no sperm at all, blocked tubes, and even couples that live apart.
If the husband comes, let's say, once or twice a year, and everything is okay, he can give a us a semen sample, we can freeze it. And we can freeze it for 5 years, even for up to 10 years. The quality remains the same. So what happens is that we can prepare this lady by giving her medications. And once she's ready, we can retrieve that semen sample, we can thaw it, prepare it, and then inject it into the woman, what we call intrauterine insemination, which is part of ART, or assisted reproductive technologies.
This can either be for the woman with a problem of conceiving. In other cases, a couple can look for a surrogate. The surrogate lends her womb to bear a child, even though the child will not be hers biologically.
If we find, for example, that this couple have problems on both sides, the semen sample is not very good, and the lady has blocked tubes, then actually the best way to help them is IVF. What we do is that we get this lady to come in, we run some blood tests, we do a scan, and if everything is okay, we start by giving her injections. And the purpose of giving these injections is that we want to prepare her ovaries so that they produce a lot more eggs. Once she is ready, we take her to theater, we get the eggs out, we do egg collection or oocyte pickup, as we call it professionally, and on the same day, the husband or the couple can actually give us a semen sample. And once he's given us a semen sample, we clean that semen sample, we remove the sperms which are not viable or not very good quality, and then we can do two things. The semen sample is good, quality is okay. We can take a droplet of the sperm, we put it together with the egg in a container, and we leave them there so that one of the sperms can actually fertilize the eggs. That is the classic IVF, that's it, in vitro fertilization.
A full cycle of IVF takes 3 weeks, roughly 21 days. The embryos can be frozen for 30,000 shillings a year in this center, frozen in liquid nitrogen at negative 196 degrees.
Then we'll transfer this into the womb of the woman. So now, once we finish with the transfer, so we finished actually a cycle of treatment. Then the lady has to wait for 2 weeks in order to see whether it is possible, whether she has got pregnant or whether she has not got pregnant.
We sit with the patients with the counseling because they would have had series of failures elsewhere, and they really look for something special in each center where they enter. So it's not only for the patient's journey through infertility, it's even like for the doctors as well.
But the cycle is very expensive. It varies with the packages each center offers. In Kenya, it costs between 400,000 to 600,000 shillings, and it is not a guarantee that every cycle will be successful. Early age, a normal semen sample, a good womb lining without growths, better egg and semen quality raise the chances of a cycle working.
It is estimated that about 6 million Kenyans have problems with infertility. But how many of them can afford a center like this or the IVF services? And does the need and the demand match the number of specialists available or even the centers that are there?
In Kenya, we have 3 embryologists, who are trained embryologists, and 2 of them are actually doctors. So they are not actually practicing embryology. So indigenous Kenyans, we have only 3, and there's only 1 who is practicing. There are about 10 or 11 centers so far. Most of these centers are, I'd say, smallish centers.
But what about women like Hellen and Priscah back in the rural areas?
Utapataje yake? Yangu naweza toa, lakini yake nitapataje?
IVF inamaanisha.
And about God being the giver of life, we cannot legislate on that, but we know God uses human beings to inject us when we are sick. So God can use human beings to assist us when we are having challenges of reproduction.
Honorable Millie Odhiambo Mabona, then MP for Mbita, tabled in the 11th Parliament the IVF Bill, which was later renamed the Assisted Reproductive Technology Bill.
What I'm trying to do is to provide a framework, one, to make it cheaper.
For Millie, now MP for Suba North, the push for a legal framework is also personal. The 52-year-old legislator does not have biological children of her own, both for health reasons and the nature of her work.
There are people who are actually saying that they cannot elect a woman who is a Luur. And I remember a number of, women. One of my opponents was using a lot of women to go around and, say, oh, this woman has no child.
The bill sought to make ART more affordable, to have insurance cover procedures, put in place guidelines and even register the practitioners. It also proposed an authority to regulate the process.
So it died at Senate after having been passed overwhelmingly at the National Assembly. So I've reintroduced it again, and it has gone through, I have appeared before the Committee of Health, and again it has received a lot of support from the Committee of Health, and it is going to go through the pre-publication processes, public participation, and then publishing, and then first reading. So I'm just waiting for those processes, and then it comes to the floor of the House.
By bringing this law in, either we have a body where everybody who practices infertility medicine has to be registered, must be registered. Medications are very important. So if it is possible for the government to sort of either reduce the tax that is paid on the medications, for NHIF to step in and help, it would be a huge, huge help.
But at the end of the day, when we see the joy of the baby with our eyes and you hold them in the arms, that motherhood will really make you go through that whole procedure.
Priscah has made peace with her womb. It has waited far too long. Even if she were to get a baby at her age of 64, we ask Dr. Omanwa if it is also too late for Hellen, who is still in her 40s.
Yes, too late if they're to use their own eggs. But no, if they're to use donor eggs. We can use donor eggs, and actually these ladies can get pregnant. Theoretically, they can do that. There's no problem. The only thing is that the older we become, the higher the chances of other obstetric complications coming in.
She would become a seraph figure whose existence is defined by the miracle of birth past menopause. Hellen stills herself to look strong, but the Luur also cry. In Dilema, true character is revealed.
He may develop hypertension, pia na ulcers.
Does a childless man and woman keep on trying? Do they accept assistance? Do they seek out a surrogate? Do they give up and accept their fate and place? It is the choices a human being makes under pressure that reveal who they really are.
Na mimi je, hata kama ni mimi, wacha tu iwe juu yangu, lakini hata mimi ni binadamu.
Dorcas Wangira, Citizen TV.